Sue, you're on mute.
Sorry about that. We spend half our lives muting and unmuting. So I'm glad to be able to introduce Grand Rounds, which is for genetics and metabolism, because I can introduce you to my colleague and friend, Dr. Bill Dobbins. Bill's recently joined our genetics and metabolism division as the new division director, bringing his experience as a renowned neurogeneticist to our group. We're fortunate Bill is familiar with our department. He brings the particular expertise of being boarded in both child neurology and genetics. He's a product of the upper Midwest, having graduated from the Mayo Medical School and completing his pediatric residency at the Gunderson Clinic, with pediatric training at the Baylor College of Medicine, who's, of course, that's the alma mater of two of our newest faculty members. So we're kind of a Baylor place these days. He completed medical genetics training at Mayo Clinic and began his academic career at Indiana University. I actually became friends with Bill when he returned to Minnesota to be a colleague in the Department of Neurology, where he was a member of our faculty until 1998. He then was drawn to the University of Chicago and remained there until he moved to the University of Washington to pursue special opportunities for his research in brain development. We were lucky to lure him back here to be our division director, but throughout his time away, Bill remained a colleague and significant contributor to the clinical care for children with complex neurodevelopmental issues. He particularly remained close to all of us, and most notably to our beloved colleague, Dr. Mariella Pierpont. So Bill is best known nationally and internationally as a neurogeneticist with expertise in brain development, but today he's going to share some of the interests he has with a unique phenomenon, that of twinning. So I'm looking forward to all of you becoming familiar with his expertise, as he adds so much to our clinical genetics service. So today's Grand Round should be an introduction to that. So please welcome Dr. Bill Dobbins.
Thank you very much, Sue. And hello, everybody, and welcome to Grand Rounds today. As you can see from the first slide, I'm going to start briefly with a chat about our recently deceased friend, Dr. Mariella Pierpont. Mariella was an icon at the University of Minnesota in the upper Midwest for almost 4 decades, and a close personal friend of mine for at least 30 of those years. So Rini and Sue and I, along with a colleague, have written a memorial for her that's going to be published, and I will circulate that when ready. So I'm going to skip to, I think, what she really meant to us. And as an academician, she was an expert in cardiovascular genetics. She trained in genetics before fellowships were really formed, and then did a complete 3-year fellowship in pediatric cardiology here at the U. So she was one of the few double boarded in those 2 specialties. And she began her career really writing about cardiovascular genetics and ending with a textbook in the late 1980s, published with our former chair, Jim Moeller, really reviewing the basic knowledge and establishing the basic knowledge of cardiovascular genetics, recurrence risk, et cetera, back then. She described a number of other disorders, one known as Pierpont syndrome, and identified the gene. She worked with me on one particular project back in the 90s, Joubert syndrome, was presumed to be a brain-only syndrome with rare retinal problems or nephronephthesis. Working over the course of almost a year with a medical student, the son of Leon Satran, or Dan Satran, we defined a wide spectrum of phenotypes associated with Joubert-like syndromes, and that basically predicted the remarkable genetic heterogeneity of the ciliopathies seen in the 20 years since. Her last 10 or 15 years, she worked primarily on the RASopathies, Noonan syndrome, and cardiovascular syndrome. And here she is at a meeting with, if you look in the lower right, the woman with the white slacks and blue shirt, third from the left, is Peggy Noonan. And there's Mariella 2 spots from her. At that same meeting, which was in Seattle and where I had lunch with Mariella, she attended it and had a great picture with her daughter, Rini, and one of her grandchildren. So for many years, Mariella was an icon for medical genetics. She was a go-to geneticist, and wherever I was in the country, if there was some piece of genetic lore that I didn't know, and there were a lot of them, she was the person I would call to get caught up really, really quickly. As you know, Mariella was a talker. and she could carry a conversation, and which she did with me many, many times. And in one famous incident, we were out for lunch on Oak Street at a Vietnamese restaurant, and we talked the whole time, and walking back, we kept on talking. And suddenly, as we got close to the Moose Tower, she stopped talking. Only after a few moments did I turn and look, and there she was on the ground with what turned out to be a broken leg. Anyway, so we should have been paying more attention to our walking than our talking at the time. She recovered, and again, proved to be an icon in the Twin Cities and the Upper Midwest, and one of the best geneticists in the country for the last almost 4 decades. So God bless Mariella. Turning from that now, which was a wonderful start that I really wanted to speak about, I'm going to turn to my topic today, which is twins. So here I am coming in as the new division director of medical genetics, and I'm going to start by not talking about genetics. What the field of medical genetics has sort of morphed into being is not just simply the experts, the go-to specialists for rare genetic syndromes and for genetic testing, but also for a wide spectrum of disorders of just what on earth is that? When it's unrecognized, some unusual pattern, they end up falling into our hands. And so here's one of them. It turns out that there are sets of phenotypes across most of the organ systems that make up all of the divisions in our department that just don't seem to be resolved with exome sequencing or genome sequencing. And we know what these are, and some of them are relatively common. I'll throw one out: gastroschisis and another intestinal atresia in the GI division. What are these, and how do we sort out? Because sometimes they are genetic. And so, the approach that we take in thinking about this is what I'm going to review today, and it takes a lot of data. So there are significant risks for neurodevelopmental disorders in twins. You've all heard of this over many, many years. It turns out that the risk is particularly high in monozygotic twins. Here's a paper from Karen Nelson in the famous Collaborative Project, in which she talked about the risk, noted that the major risk was probably prematurity. But there are other risk factors. The problem comes in so many of the later reports. If you look on the right, this was a very well-designed study, but it focused on monochorionic diamnionic twins. That is a surrogate for monozygotic twins. All right, so the assumption here is, though they're dizygotic twins, that they can be premature, but otherwise they're fine. Well, let's find out about that. And so this is a wide-ranging assumption in the literature, and dizygotic twins are largely ignored in large studies of twins. All right, so here's an example of a study. This one came from Seattle Children's Hospital. The senior author is one of the founders of medical genetics, Dr. David Smith. If you look on the numbers on the right, I want you to focus on a couple of things. One, the proportion of male-male twin pairs was 17 to only 3 female-female twin pairs, and only 1 of mixed sex. And when you use the Weinberg method to calculate zygosity, that means that there was about a 9-to-1 ratio monozygotic to dizygotic. And that's kind of been the idea across large numbers of studies of twins. It's monozygotic twins, monozygotic twins, monozygotic twins. And sure, they are at higher risk, but dizygotic twins have largely been ignored. And we're going to look into that a little bit today. Here's another paper on schizocephaly, or cleft brain. This just looking at the birth defects data from the state of California. And what they found here is that not only was there abnormally young maternal age, an interesting factor, but there was also an increased risk for twins and other multiple births. And this was not in a study of twins per se, but of the birth defect schizocephaly. Here's another point. And so for those of you who are not neurologists, here's all of the other phenotypes, or at least many of the other phenotypes that you see in association with schizocephaly. What we will find out is these are also observed at increased frequency in twins. All right, so before really diving into my twin data set, let's think about the placenta a little bit. So the placenta in twins is where all the problems seem to start. And certainly it is the origin of the most common abnormality that now is dealt with by maternal-fetal medicine in twins, which is the twin-twin transfusion syndrome. This can be divided into sort of 2 halves, one with large vessel anastomoses. The twins, the donor gets oligohydramnios and the recipient polyhydramnios for the TOPS sequence. when there are few large vessel, but mostly small vessel anomalies, the donor twin gets anemia and the recipient twin polycythemia, the TAPS sequence. And so if an MFM specialist laser coagulates enough of the large vessel anastomoses but misses the small, they can convert TOPS to TAPS. Anyway, this is a significant problem. So here is a placenta. In the left column are dichorionic, diamniotic placentas. And what you can see here is this very thick, rind separating the two placentas. And that comes because there's two chorions and two amnions sort of fused together there. Whereas over in the right column, you can see a monochorionic diamniotic placenta with a much more subtle division shown by the red arrow. When you look at the membranes, the di-di membranes are opaque, whereas the mono-di are translucent. And you can see this with pathology quite simply. Over in the lower right, you can see there's two chorions there, fused together. So here's what happens when you get into twin-twin transfusion syndrome, or Ttts. So you can see the difference in the placenta. It's pretty obvious. A donor placenta on the right and the recipient on the left with far, far more blood. And you can see some of the connections. So here are some of the large connections. Here in the one that says large vessels TOPS, I think this is just after this one has been photocoagulated. You can see one of the tiny vessels. What they did here was inject a black dye into one umbilical cord and a red into the other. You can see the recipient histology shows much more blood than in the donor. And the donor one's actually thicker. So this is a really striking differences in the placenta. All right, now here is the most important, what I believe is the most important paper on twins and twin placentas that you've never heard of. So this was a study of some 1,500 or more twin placentas done at the University of British Columbia in Vancouver. And when I first read this, I really didn't quite get it, but I've gone back to this and read it over and over and over again. And what I want you to do is to first look at table 1 here. And what I've done is cut off a lot of other data. We're just going to look at the top 2 features of placental inflammation, and especially the bottom 2, abnormal vascular anastomoses and unequal placental sharing. We'll look in particular at placental sharing, although all these parameters end up teaching the same lesson. Here in males, unequal placental sharing seen in 37.2%, in females only 27.6%, a highly significant difference. All right, here they took all twins, whether monozygotic or dizygotic, or whether they were DC-DC or MC-DC, and combined them together and separated them by sex of the twin and that twin's placenta. All right, and so it's common, well actually it's not common, in large twin studies they occasionally talk about sex, but most of them remarkably never do. They never do, which I find remarkable given the data I'm about to show you. So when you start going further and saying, well, it's not just males and female twins, we have twin pairs. They can be male-male or female-female. They can be male-female. And so when they're same-sex twins, they can be either monozygotic or dizygotic, although that's where all the monozygotic twins are, of course, going to be. All right, so let's look at the data here when you look at twin pair sex. Remarkably, for unequal placental sharing, the same for abnormal anastomosis. If you look at this, the male from a same-sex male twin pair is the highest rate of unequal placental sharing, followed by females from the same-sex twin pair, followed by males from unlike sex pairs, which are all dizygotic, and then least the females from dizygotic. And so clearly, the lesson here is, one, males seem to have placental abnormalities more frequently than females. And I think that's a big deal. In other words, it's probably not all about the X chromosome when males have more problems at birth than females. The other important lesson is this is not only about monozygotic twins. So dizygotic twins are about twice as common as monozygotic twins. But if you look at this data here, they do have the abnormal placental inflammation and abnormal vascular connections in dizygotic twin placentas. So maybe the rate will be lower, but they should have all of the potential, twin-twin vascular problems that monozygotic twins have, perhaps less severe, perhaps less often, but they should have them. And the literature really does not talk about that. All right, so what do you do about that? So I've thought about twins and talked to some of the national twin experts for years, but here in my database, I've been accumulating reports of twins with structural brain abnormalities for years. And if you look way up at the top under the little ST or for state, the fourth one down is actually Minnesota. We'll hear a little bit about that young woman in a little bit. Anyway, so I went through and pulled all of the twins from my large database that I've accumulated over 30 years, and I had a lot of them. Not only that, I pulled the literature on twins, but not just big twin series, because those provided no individual level data on twins. I curated the literature only for those reports where they actually presented a brain imaging, neuropathology, or a detailed description of a twin. Here, for example, is a twin with intrauterine fetal demise of the co-twin with polymicrogyria, and what these show over here are heterotopia in the middle of the white matter, or subcortical nodular heterotopia. Here are paraventricular heterotopia and an overlying polymicrogyria. All right, so here's what the data looks like. So from the literature, over about 50 years, we were able to find 48 reports of a structural abnormality. It could be a malformation of the cortex, of the cerebellum, or just brain disruption like porencephaly or hydranencephaly. In my own twin series, I was actually able to get, after throwing out the genetic disorders and those with too little data, I was able to find 56 probands and I think 6 or 7 affected co-twins. What you can see here is in both my series and the literature, the sex ratio is about the same. There's a few more males, which is a little bit of a red flag. It didn't turn out to be significant, but with large numbers, I kind of wonder. Look at the zygosity. Now, the literature, tells you that it's all monozygotic twins. 1 dizygotic out of 45 monozygotic out of these 48 individuals, and 2 unknown. But you look at my data, that's absolutely not the case. We had almost a 50-50 split, and I'll come back to that. But what were these phenotypes? All right, so here is a case from Boston. I think the Brigham and Women's back in the late 1990s, given to me by Dr. Robert Hevner. What you see here is twin B of a monozygotic twin pregnancy. Twin A died, was okay. They were both okay at 15 weeks. At 22 weeks, twin A had died. Twin B was fine. But by 23 weeks, ultrasounds of twin B showed ventriculomegaly, and by the following week, twin B had died. The twins were delivered as stillborns, and you can see the brain of twin B on the right, where the frontal lobe here is just sort of irregular and sort of shrunken, and you can see the start. This is polymicrogyria before it really forms into the full form. So it's developing polymicrogyria here. You can see the loss of brain volume in the superior part of the frontal lobes here in figure D. So this turns out to be the very best example of dating of polymicrogyria in a pregnancy ever. All right, here is my old note from 1998 with the name taken out, a young girl I saw from Des Moines, Iowa in my then neurology clinic. It turns out that, I thought that this might be polymicrogyria, and I thought there were white matter problems, but what a crummy MRI scan done. You can see these sort of little white dots back here, and I call that cystic changes of white matter. The gyri are just bundled up over the frontal lobes. That's probably polymicrogyria, but it was a crummy scan. Well, it turns out that this family moved to the region between Seattle and Tacoma a couple of years after I saw them, and arrived there probably 5 to 7 years before I moved to Seattle. And I was able to see her again in 2012 when she was 14 and a half years old at Seattle Children's Hospital in clinic, and sort of reconnected. She was microcephalic at that time, and interestingly had hypopituitarism, panhypopituitarism, which is one of those things you should think about from septo-optic dysplasia, which is another one of the presumed vascular phenotypes. Anyway, so this young lady was very ill and kept getting ill, and finally passed away a couple of years after I saw her in Seattle. And her parents were kind enough to reach out and allow us to examine her brain. And so what you see here is areas over her parietal lobe, mostly that kind of look sunken and wrinkled. You can see those over here in G, for example. They're not really well seen. Look in H, down right around the ventricle, you can see some subtle gray areas. Those are paraventricular heterotopia. Right in the middle of H over on the left, here are some subcortical heterotopia. These are hard to see. Oh, and here are the cystic lesions on I. But in K, in the H and E, here you can very easily see the thick cortex. Here, the paraventricular heterotopia with the asterisks and these arrowheads are all of these scattered subcortical heterotopia. So really defining the sort of phenotypes that I've been seeing on brain imaging for years. Now, importantly, this was a pair of dizygotic twins. This girl had a twin brother. All right, so here's the next most important case, and this is a set of monozygotic twin boys from Fresno, California. You can see the affected boy in the lower right. His arms aren't quite right. We'll visit that further in the next slide. But what I want you to see here is all of these remarkable malformations of the cerebral cortex with red circles now. So we have a huge but asymmetric subcortical heterotopia. We have some polymicrogyria that you can see in the lower left here in the circles. But importantly, look at these little columns of gray stuff going from the paraventricular neuronal tissue up to the cortex. So subcolumnar heterotopia. You can see another thin one right here. Turns out that these ended up not being rare in twins with cortical malformations. I saw a lot of this. And so a vascular pathogenesis has not previously been suggested for subcortical heterotopia like this, but here you are. Turns out that this boy was perhaps the most instructive of our entire series and one of the most instructive patients I've ever seen. So here he is as a newborn, and you can see that those two very extended arms. So he has three-limb amyoplasia, amyoplasia being the most common form of arthrogryposis multiplex congenita. But on top of that, he's got cerebellar malformations. You can see an asymmetric cerebellar hemispheres and a cleft in the cerebellum, particularly in the peduncle right here in the lower images. But at the top, here you have a classic Dandy-Walker malformation meeting every criteria: small vermis, upprotated vermis, and very large posterior fossa. And that really has not been reported, at least it's not appreciated. It has in fact been reported in twins. All right, here's another child from Seattle. Here the polymicrogyria is mildly asymmetric, not quite as obvious, but for all of the non-neuro people here, let's look at the rest of her phenotype. So this girl was born with intestinal atresia. In addition, she had congenital contractures affecting primarily her lower legs and feet. She has dimples over both of her hips. And again, she had club feet, and so is still having difficulty standing. She's only mildly delayed. So she's got much more than just the cortical malformation on her brain scan. And so these are sort of just one more example of multiple associated defects in twins. So most of you are probably not brain scan groupies like me, so I'm going to go through these relatively quickly to get to sort of the take-home messages in a bit. But here are some brain images of variable quality, some of them very good, from twins. Most of them monozygotic, but a healthy proportion of dizygotic as well. So here we have a child with schizocephaly or cleft brain, and we saw quite a few of these, and it appears to be part of the spectrum. So I'm going to stop treating it like a separate birth defect called schizocephaly and just call it polymicrogyria with cleft. And here is a cleft seen in B, and it's an open lip cleft. You can see the large sort of porencephaly in C and D. Down in the lower image, you see just a striking asymmetry. There is some polymicrogyria with that small arrow on the left in F. That's actually the right side of the brain, much more on the contralateral side. So significant asymmetry, which I saw frequently in the twin cohort. Here's another example. Up here, you can see a very thin corpus callosum, which is not surprising when you see that this is frontal predominant cortical malformation. And on the lower, we just see, again, a mild asymmetry, a little bit worse over on the right side of the screen, which is the left brain. All right, here is a child with really good images. And what you can see is very deep infolding of the polymicrogyria, which is a recurring theme. We often saw that. In particular, you can see this in F, G, and H, where it's just gyri extending far, far into the white matter. And here is another child, much more subtle. If you look here, there's the polymicrogyria with the big arrow in J, and the arrowhead shows a little subcortical heterotopia. You go from J to K, and look at that little column meandering up from the periventricular heterotopia up to the cortex, a subcortical columnar heterotopia, shown again in O. You know, you've seen these before. They are not common, but in a large twin cohort with structural abnormalities, not so rare. All right, what do we have here? This is an example of simply cerebellar hyperplasia, which is not widely appreciated in twins, but sure enough, here is a small vermis and the cerebellum is small. You can actually see a cleft here in the cerebellar, low cerebellar hemisphere here, best seen over in D. And you can see in H the asymmetry that's quite common in the cohort, not only in the cerebral cortex, but here you see it in the cerebellum. And once again, here we are with classic Dandy Walker malformation, a couple more twins. Here's what you sort of come to expect with twins. This is sort of a post-malformation injury. So this would be hydranencephaly and porencephaly or multicystic encephalopathy or just diffuse white matter loss. Again, you see this is seen in twins, some with microcephaly as in EFGH and some without. And here's another example, just a little bit less severe, lots of loss of white matter here. You can see it both in the front or the back, although the back is probably a bit more common. All right, so let's go back to my data and sort of pull this together. What does this really mean? So what we have here, the important stuff here, one, we've got a mild excess of males. It turned out to be not statistically significant. I'd love to have a cohort of 1,000. Zygosity is almost equal, which is very, very different than I expected from what has been reported in the literature. So here's kind of what this looks like in more graphic form. I see more cortical malformations than other types, but that may be just an ascertainment bias of what is sent to me. So I have an ascertainment bias for severe brain abnormalities, but I do not have an ascertainment bias, of course, for MZ versus DZ twins. A bundle of them had intrauterine fetal demise. I will talk about that in a bit, but you can see how very, very different the dizygotic to monozygotic DZ to MZ ratio is in the reported literature compared to mine. Just take a look at that. So what I wanted to do here was examine the population ratio from that same Vancouver study, which I like to use that one because they had such excellent documentation of the chorionicity and amnionicity. So I had a pretty good idea of what the DZ to MZ ratio was, and this certainly matches the literature. 2/3 DZ, 1/3 MZ. So in my series, I had about even numbers, and the difference between the population cohort and my cohort was statistically significant. My cohort was also dramatically statistically different from the literature cohort, which to me suggests a ton of ascertainment bias in the literature, which had a lot of examples of intrauterine fetal demise or IOFD, and a chi-square comparing all three of these was highly significant as well. So anyway, so what we're seeing here is a significantly increased risk in MZ twins, but it's not only about MZ twins. You see these in both DZ and MZ twins, and that really is not widely enough appreciated in the literature. This is just not just the effects of prematurity, but effects of twinning. All right, now again, for the non-brain gurus here, let's take a look at all of the associated abnormalities in my cohort and a couple from the literature. This is not a comprehensive list, but it's pretty good. Optic nerve hypoplasia and panhypopit from the girl from Iowa. Congenital cutis aplasia, club feet, amniotic band disruption, amyoplasia, jejunal atresia, multiple intestinal atresias. Here, one example with 13 sites, one with 8. Gastroschisis, more leg contractures and club feet, and then 2 of the big arrows. This is a new one, vocal cord paralysis. I wouldn't have thought this was a vascular associated or twinning associated problem, but we've got 2 of them. I also have 4 or 5 others in singletons with polymicrogyria. So there's probably something to this as a novel vascular phenotype. All right, and here are some of the other examples that I've sort of summarized. There's a lot of different abnormalities in brain. When you look at these as a geneticist, most of these are the sort of malformations that have a relatively low yield from exome sequencing. Not only that, but the abnormalities of the body on the lower right also have a low yield from exome sequencing. Now, it's not always zero for the brain, but it's pretty low. And why is that? And we'll come to that in a bit. All right, so here, what's the timing of cortical malformations and the cerebral problems in these late gestation brain disruptions like hydranencephaly? So all of the data talking about this mostly comes from examples of intrauterine fetal demise, or IUFD. What I want to show you here is that this is baloney. Okay, so look at how diverse these are for cortical malformations and cerebellar malformations and BRDS brain disruptions. They're all over the map. And so this shouldn't be too surprising. So if a twin is going to die, maybe that twin was sick for a while. That could have been days or weeks. And after that twin dies, the body's going to start to decompose, releasing all sorts of vasoactive agents into the bloodstream of the surviving twin that is potentially going to cause big problems in that twin. And so saying when the twin died, it just isn't enough, all right? So I don't really trust these data. There's a general trend for cortical malformations to occur before cerebellar malformations, and cerebellar before brain disruptions. That makes sense, but the data are soft. All right, and so in pulling it together, I've shown you a lot of examples of twins with a wide range of defects focused on the brain, but extending out into the body, especially the limb contractures and the arthrogryposis, the intestinal atresias, etc. But in the literature, there's a lot of doubt about this because it's hard to prove, because you can't go and study the fetus at the 10 weeks gestation very easily. But when you and there are reports out there that the vascular hypothesis for the underlying cause is not correct, especially for gastroschisis. So what I did here is to pull together a diverse data from the literature, and here it is. So number one, for all of these disorders in the brain and the body, including the panhypopit, the intestinal atresia, gastroschisis, amyoplasia, shared pathogenesis, they frequently co-occur. And I've got numerous examples in my twin database, and I showed you several of these. Next, in twins with these structural brain abnormalities, twin-twin transfusion system and IUGR are common. These RCFDs, that's my term for all of these vascular-associated, twinning-associated disorders, are recurrent constellations of fetal disruption. I separate these from other twin-associated early abnormalities like Vater, which occur much, much earlier. All right, so these, the RCFDs are frequently seen with twin-twin transfusion syndrome and IUGR, typically in the donor twin. Third, vascular territories. Pathologists have long noted that the polymicrogyria schizocephaly tend to occur in specific vascular distributions, especially the middle cerebral artery. 4, there are shared risk factors, vasoactive exposures, and there is extensive literature suggesting some increased risk for vascular problems with young maternal age, high estrogen levels, smoking, and other risk factors. 5, here's a big one. Defects in vasculogenesis have been well documented outside of twins to be associated with the same brain abnormalities, polymicrogyria, et cetera, that I've been showing you. First, intracranial or neck vascular anomalies, such as unilateral hyperplasia or absence of the internal carotid, has been seen with both cerebellar problems and with cortical problems, especially polymicrogyria. This is, for example, been seen in DeGeorge syndrome, deletion 22q11, where the key gene is an important vasculogenesis gene, TVX1. I've seen it with the deletion of 6p21, including the critical VEGF-A gene, an important gene in endothelial vasculogenesis. And in Facey syndrome, that's the rare one with huge facial hemangiomas and posterior fossa abnormalities, sternal and heart defects with no known genetic cause. The most common brain intracranial abnormality with that is actually not a brain malformation, but defects of intracranial vessels or the carotid. Next, vascular malformations have been associated with polymicrogyria and cerebellar problems. They've been reported many times adjacent to brain AVMs, and they have been repetitively reported in hereditary hemorrhagic telangiectasia. Finally, prenatal hemorrhage in the fetal brain has been seen with both PMG, especially PMG with clefts, and with cerebellar bleeds, particularly with several examples with classic Dandy-Walker malformation. So here, what we have is a wide range of birth defects and later, presumably third trimester disruptions that appear to be associated with twins, and the vascular perfusion and hemorrhage seem to be the underlying, basic cause. And so these are not genetic, but I've shown you examples where the final common pathway can be the same. So if you have a genetic defect of a gene that's a critical actor in vasculogenesis, you can get the same basic spectrum of phenotypes. That's a hypothesis at this point, but it's getting to be stronger and stronger, and I've published this for cerebellar malformations. So there we have, again, a wide range of phenotypes associated with twins that gives us, I think, a deeper understanding of the underlying pathogenesis, and that vascular perfusion and hemorrhage really are the basis. When you review all of the data, it's actually a lot stronger than any one paper. And here is some photos from my backyard last year, another reason I wanted to come back home to Minnesota. And so thanks everybody, and I will take questions.
So Bill, I'm going to start with a question. This is Sue. Do you see any mechanism by which knowing these risks could occur that preemptive care could improve outcomes?
We don't know any yet, so no, I really don't. So the underlying causes, so the first issue is, when do these really occur? Well, I'm sorry, I forget, twin-twin transfusion syndrome, of course. Ttts can be treated and is being treated very actively by MFM specialists by laser coagulation of these connections, and that has made a huge improvement in the impact. But of course, you need to diagnose that quickly, very early. One of the things that I have seen here is that these brain vascular abnormalities and actually body vascular abnormalities are seen in twins in whom TTS was not recognized. And so the diagnostic criteria of TTS sort of catch the big tip of the iceberg, but they probably don't catch the whole thing. And so are there potentially ways from imaging, particularly in twins, to look harder for vascular connections when they don't meet the clear criteria with the oligo polyhydramnios or the anemia polycythemia? So that's one area. But the big problem, of course, is the twins with these disorders and vascular disruption are a relatively small part and parcel of this picture. The singletons are much more common. So there is data out there to suggest that the percentage of twins at the time of conception is double what we think the twin percentage is. So there may be a lot more of these problems that actually are due to twin placentas, just too early to recognize. But we really don't have a fix for singleton placentas at this point, and it's clearly not a twin-twin transfusion syndrome or an anastomoses, but could this be a vascular problem, getting blood from mom to placenta to baby? Yes, but I don't have a clear way to fix that at this point. Could the mother be given supplemental oxygen? Well, we don't know when, although there are hints that the timing starts in the mid-teens. For example, amyoplasia is best dated to 10 to 12 weeks. PMG is probably in the 13, 16-week range, for example, but it's hard. So the answer is not yet.
Dr. Orchard asks, on what basis does the sex of twins affect the integrity and architecture of the vascularity of the placenta, and why would zygosity matter?
So zygosity matters because they're in dichorionic diamniotic pregnancies, which are most dizygotic twins, there's a very thick separation between the two placentas that allows few vessels to cross and anastomose, although, as I've showed from the Jahanfar paper, there are some, right? So the real question, I think, is here is males and females. Why are there more problems with placental inflammation and vascular anastomosis in male compared to female placentas? We have no clue. We have no clue. So what I will say here is this has been an eye-opener for me. Could the same thing be true for singleton male compared to female placentas? Maybe so. So one of the things we have been blaming, we say, so we know that there are more males with developmental problems at birth than females. And taking the cortical malformation polymicrogyria, there is large data from myself and my former trainee, Dr. Rick Leventer, saying that it's more common in males than females. And we have gone chasing after X-linked causes for forever, finding nothing, nothing, nothing. So I am wondering whether the difference between male and female placentas is actually a big, big deal for neurodevelopmental disabilities. And we have no clue why this is at this point.
So thank you for that awesome presentation from Erin Stepka. She asks, as a neonatologist, do you have any recommendations regarding IUGR twins about imaging and follow-up, for example, MRI or other studies?
So there is so prenatally, any twin needs to get followed very, very closely by MFM. And, as I talk to MFM, I'm going to be talking to them about, what are their diagnostic criteria for Ttts, and do those need to be expanded? After birth, there are large studies that do not present individual level data, suggesting that the brain MRIs are normal, maybe there's some mild white matter problems, etc. I don't know about that. I think there may be more to it than that, and that we just haven't looked at it carefully enough. So I think, does diagnosing that on a brain scan really help you? Well, what I would have is certainly an increased sensitivity to ordering brain scans in twins after birth, if there's any abnormalities. But it's not just in neonatologists. I would go to their pediatrician over the first year of life. If there are any delays, there should be a very high index of suspicion. And one of the big deals here is why should we be chasing genetic abnormalities when we have these birth defects? And the answer is actually sometimes we should, because genetic genes expressed in vasculogenesis can follow the same final common pathway. But this is a big and important question that we really don't understand. And what I've done here is bring out a couple of additional phenotypes that could be part of the vascular perfusion sequence. Vocal cord paralysis is one, and the other is it's severe orofacial dyspraxia, a motor speech dyspraxia or apraxia. I think that is potentially another vascular-based perfusion problem or phenotype, sometimes called Wooster-Drought syndrome. And that is actually more frequent in boys as well. So there are more subtle phenotypes out there that I think we have probably not recognized.
So here, another question. Polymicrogyria makes one think of neuronal migration defects, some of which are triggered by infection in utero, genetic issues like Reelin. So is there a unifying hypothesis with what you observe in twins, or is this truly a heterogeneous collection of etiologies? And then,
so it is a mistake from the literature by both neuropathologists and especially radiology literature to imply that polymicrogyria is a neuronal migration defect. It is not. It is the defect is injury to the developing cortex or a genetic problem leading to injury to the developing cortex during critical phases of development. Now, the classic neuronal migration disorder is Schizocephaly, how I started my career. Those look very different. There are a number of other genetic disorders that look like polymicrogyria. The classic ones would be the tubulinopathies, all called polymicrogyria, but once you learn them and look at them, I can tell the difference in about 5 seconds. There really are differences. Those are neuronal migration disorders. But for classic PMG, which is the most common cortical malformation by far, it's not a defect of cortical migration. It's a defect of really post-migration cortical development mixed in with an injury. So really critical difference.
All right. I don't see other questions in either the Q&A or the chat. So I think that allows us to give people back maybe 10 minutes of time. Thank you so much, Bill. I think that was a fantastic talk and very erudite, and we appreciate that.
Thank you, Bill. Have a good day. Have a good day, all.
All right, thanks. Bye-bye, everybody.
Bye-bye.